நான் வரல சார் இந்த டைம்.
அப்புறம் எப்படி சார் ஸ்டேஜ் நீங்க இல்லாம நடக்குது?
அர்ச்சனா அண்ட் சந்தீப் சார். சார் எப்படி சார் எல்லாத்துக்குமே போயிட்டே இருக்கிறது? டிபார்ட்மெண்ட்லயே எல்லாம் ரெண்டு டைம் 3 பேர் 4 பேர் போனாலும் கஷ்டம். So being live stream.
Shall we start, sir?
We can, sir, Dr. Suresh Kumar, sir, please.
Yeah. Good evening and welcome everyone. We will start our 17th edition of Pudukkottai Budan, organized by ISA Pudukkottai City Branch. At the outset, I welcome our Honorary Secretary, Dr. Perivascular sir, to go for the welcome address.
Thank you, sir. Good evening to everybody, everyone all. I am Dr. Perivascular, Secretary, ISA Pudukkottai. Welcome you all for this 17th webinar ISA online conference hosted by ISA Pudukkottai. This is a newly created branch, Pudukkottai branch, in the year 2019. So first we conducted one workshop with the CME program at Pudukkottai. And next mega event, this is the online program, especially for PGs and practicing anesthesiologists. This online program is going on from March onwards. So once again, I want to welcome you all for this online program on behalf of ISA Pudukkottai. This is named as Pudukkottai Budan. Budan is the auspicious day of our Tamil culture, so we name it as a Pudukkottai Budan. In the past, from March 23rd onwards, we conducted so many programs with so many topics, especially for PGs in their exam point of view, with the various eminent professors and from all over the country, from All India Medical Institute and Mumbai, other part of the country. So many professors were participated in the event, and today we are conducting the 17th program of this online program. So I welcome our academic chairman, Dr. A.L. Meenachundram sir, for his effort and hard work to make this program successfully conducted for the past 3 months, and our President Dr. Suresh Kumar sir for his support and guidance, and my treasurer Dr. David for his financial support, and our association members and colleagues from various part of the country. I welcome you all for this Pudukkottai Budan event, sir. Today we are having so many speakers from Ganga Hospital, and as the chairman, I welcome Dr. Sivasanmugam, Professor, Mahatma Gandhi Medical College and Research Institute, Pondicherry. I welcome you, sir. Next, we are having speakers for this today program. Dr. Pavitra Palaniyappan, madam, is going to talk about adjuvant to local anesthetics. Madam is working as a fellow in regional anesthesia, Ganga Hospital, Coimbatore, India. Welcome you, madam. Next speaker, Dr. Santosh Kumar, junior resident, Ganga Hospital, junior consultant, Ganga Hospital, Coimbatore. Sir is going to talk about Subclavian Perivascular block. Welcome you, sir, on behalf of ISA Pudukkottai. Next, junior resident, Dr. Mangair Karasi, postgraduate, Ganga Hospital, Coimbatore. Madam is going to talk about local anesthetic systemic toxicity. Welcome you, madam, on behalf of ISA Pudukkottai. Next, regarding this medical council credit hours, we already started to get credit hours in all the CMEs. So for that, you have to we record your email ID, mobile number, or attendance screenshot, and payment 100 rupees for our branch account number 3856859628, and with these details you send email to isapudukottai@yahoo.com. Okay, today we are having this topic related to local anesthetics. Amidst a small poem about that. Amidst acts on the nerves, reacts on the volume curve, blood volume curve. Amidst takes both in the CSF, travels through the nerve roots. Amidst are pain alleviating drugs and arrhythmia stopping drugs. Amidst abolishes all the reflexes below its control and relaxes all the muscle masses. Amidst sword of anesthesiologist, and so it is an award for mankind. With this, I conclude my welcome address. Thank you all. Thank you, sir.
Thank you, Dr. Perivascular.
Thanks.
Respected academic chairman, Dr. A.L.M. sir, treasurer, Dr. David, today's chairperson, Dr. Sivasanugam sir from Pondicherry, respected Dr. Balavengat sir from Ganga Hospital, Coimbatore, today's speakers, Dr. Pavitra, Dr. Santosh Kumar, and Dr. Mangeer Karasi from Ganga Hospital, Coimbatore, assembled postgraduates and practicing anesthesiologists who are attending the webinar. Once again, I welcome you for our webinar on local anesthetics. We, ISA Pudukkottai branch, successfully conducting the webinars for today is the 17th edition for the past 4 months. But today is a special day on many occasions. Today is a Guru Purnima day. On behalf of ISA Pudukkottai and all of our members, I extend my warm wishes and pranams to all our beloved teachers who are made us anesthesiologists. And we should also forget our patients because they have subjected themselves for our learning curve. And at this time, I wish all our patients also on this Guru Purnima day. And another special thing is today we have local anesthetic topic, because in and out in our practicing anesthesiology we are using local anesthetics, and our ALM sir has chosen this nice topic which will be immensely useful for our postgraduates and practicing anesthesiologists. And another one special is we have our chairperson who has mastered the local anesthetic technique and have given so many outputs during this past decade regarding these blocks, the action of local anesthetics, and the limitation of local anesthetics to the amount of 2 ml, 3 ml he has given us. And lastly, the topic speakers are from Ganga Hospital. We cannot forget Ganga Hospital, because in Tamil Nadu, Ganga Hospital has revolutionized the management of patient care with the help of so many regional blocks, and at the leadership of our Dr. Balavengat sir. And we cannot also forget, every year they are conducting a wonderful academic program, GARC, which they invite so many delegates from all over India, speakers from all over India and abroad. Every year I used to attend this at this time. I once again thank Dr. Balavengat sir for conducting such a useful academic program. I request all the practicing anesthesiologists and postgraduates to use this program very well. I hand over the proceedings to our academic chairman, Dr. A.L.M. sir. Thank you, sir. Thank you.
Thanks, Dr. Suresh Kumar, President, ISA Pudukkottai. Today, as he has mentioned, it is a very great day, Guru Purnima day. Now, there are two legends in local anesthesia or regional anesthesia are here. One is Dr. Sivashanmugam, another is Dr. Balavengat. And we are happy to have Dr. Balavengat here for in the past 17 editions. The presence of Dr. Balavengat is acknowledged the second time. Opening function, inaugural function, he was there. And Dr. Balavengat this time, he is a National Governing Council member. And more than that, he is popular as Dr. Balavengat. The specialty today about him is he has pushed the youngest team possible. If you add the ages of 3 speakers in these 17 editions, this is the youngest team we had. And I don't think any more youngest team will come like this. Even though it is youngest, they are masters in their technical skill. So Dr. Balavengat is to be appreciated as he is sitting in the backdrop and he is pushing the youngsters in front. That's what we wanted to have also. So out of his experience, he has selected the creamy layer of his trainees and he has pushed them in front. So we thank him first, Dr. Balavengat. Then regarding the speakers, Dr. Santosh Kumar is the senior most trainee in Ganga Hospital. He has done his MBBS in KFPB Medical College Trichy. He did his DA in KMC Manipal, and now he is doing a DPNB and a fellowship, a postdoctoral fellowship in trauma anesthesiology in Ganga Hospital. Dr. Pavitra is also alumni of KFPB Medical College Trichy. She did her undergraduation there, and she did her MD in SRMC Chennai, and she is doing postdoctoral fellowship in regional anesthesia in Ganga Hospital. Dr. Mangayar Krasi, a resident, done her UG in Theni Medical College, and she is doing her post-graduation in Ganga Medical College, Ganga Hospital. So everyone knows Ganga Hospital is very, very good, rather excellent as far as regional anesthesia is concerned. So whatever may be the position of the patient, even before the advent of ultrasound, all the doctors, anesthesiologists in Ganga Hospital will block any nerve. Even in a prone position, they will perform a brachial plexus block. They are very good at block. So we were worried how we have to find out a good chairperson to accommodate them as speakers. So literally it should be Dr. Balavengat. But just because he is their teacher, we wanted to have another person. And naturally, Dr. Sivashanmugam, who is excellent in ultrasound guided nerve block as well as regional block, because I have seen him. When I entered as a dean, before that 2013-14 only the ultrasound has come into vogue. So I didn't have a first-hand experience in ultrasound. So when I was a Thiruvarur Medical College dean, I went to Pondicherry. Dr. Sivashanmugam only taught me about ultrasound guided regional anesthesia, and he has demonstrated each and every nerve straight from origin to the insertion with the help of a theatre assistant. It is excellent, marvelous, and I was wondering, by seeing that we are performing a block. Then I have seen it with Balavengat performing a block in Ganga Hospital. So Dr. Sivashanmugam has performed cadaveric ultrasound guided cadaveric nerve workshop in Pudukkottai. Even at the inception, during the inauguration of ISA Pudukkottai, Dr. Sivashanmugam and Dr. Sandeep Diwan from Pune, they participated in ultrasound guided nerve block workshop. So Pudukkottai is having Dr. Sivashanmugam a second time. He is now engaged in cardiac surgery, but even then he has come. And as we expected, the phenomenal expectation from the delegates is there. Even by 6:15, 60 people have logged in. Usually only by 6:30 we will be having this figure, and this figure will swell. So I personally welcome all the speakers, and I once again thank two legendaries in regional anesthesia, Dr. Balavengat and Dr. Sivashanmugam. Now I hand over the session to Dr. Sivashanmugam, chairperson. Please, sir.
Thank you very much, sir, for that kind introduction. As everyone said that these topics, especially the brachial plexus block, local anesthetics and its adjuvants, and the most feared complication of systemic local anesthetic toxicity are the crucial areas every anesthesiologist should know. I think this is the best talk and the platform for the postgraduates and the regional anesthesia enthusiast, as well as every one anesthesiologist should know about all these aspects. So without spending much of time, let me hand over the stage to Dr. Santosh to proceed his talk on subclavian perivascular techniques. Over to Dr. Santosh.
Good evening, one and all. Good evening, one and all. Am I audible?
Yeah, you're audible, Santosh.
Yeah. Yes, sir. So, greetings from the Department of Anesthesiology, Ganga Hospital, to one and all. And today my topic is on the subclavian perivascular block. So starting with, we'll start with the anatomy of the brachial plexus. So the brachial plexus is being formed by the ventral rami of the spinal nose C5-T1. Sometimes it might get prefixed or postfixed depending upon the nose, spinal nose, which includes it, either C4 or T2. So usually C5-T1. Here the ventral rami of the spinal nose enters the muscular compartment via a groove in the transverse process. Usually the transverse process of the cervical spine is usually bifid, and you can easily find out the spinous processes by using ultrasound, and you can easily delineate what nerve is exiting, and you can easily find out the nerves also depending upon the characteristics of the transverse process. So in our landmark approaches, usually the C6 anterior tubercle, which we call it as Chesapeake tubercles, we tend to palpate and give a stellate ganglion block. But with the help of ultrasound, you can easily delineate these structures. So coming to the anatomy point, the anterior rami of the spinal nose enters the muscular compartment via this groove between the anterior and the posterior tubercle of the transverse process. So here you can see the facial planes of the neck. Usually this is the deep cervical fascia. It is called as the prevertebral part of the deep cervical fascia. And this is the investing layer of the deep cervical fascia, which invests and covers only these two muscles, which is nothing but the sternocleidomastoid and the trapezius. And as far as the compartment is concerned, there are three compartments. This is the visceral compartment, and this is the vascular compartment, and this is the muscular compartment. Each compartments are being completely covered by the facial planes. So in case of the brachial plexus, the nerve emerges through this muscular compartment and then pierces the deep cervical fascia, and then forms the interscreen groove. So usually the brachial plexus anatomy, if you see, you can see the root, and then the C5, C6, C7 and T1, C8 and T1 joins to forms the trunk, which is nothing but the upper, middle and the lower trunk. And then the trunk divides into divisions, and the divisions finally coalesce to form the cords, and the cords are being named according to the position relation to the subclavian artery. So in this session, our interest is above clavicle approach of the brachial plexus, which involves the root level, the trunk level and the division level of the brachial plexus. So this is the dissected anatomy of the brachial plexus. Here you can see the muscles which forms the anterior and posterior border of the interstitial groove. This is the anterior scalene muscle, and this is the middle scalene muscle. So here you can see the nerve emerging through the gap between the anterior and the middle scalene muscle. And then at the lower part of the groove, it is getting accompanied with the subclavian artery. Here you can see a subclavian artery and the nerve arranged posterolateral to the artery. And other nerves of interest at this point is the phrenic nerve. Phrenic nerve is being formed by the ventral rami of C3, C4, and then the C5 spinal root. And it diverges from the neck away from the brachial plexus and enters the thoracic cavity. So the phrenic nerve is an important nerve as of brachial plexus block is being concerned, because many of the time with a landmark technique or a PNS technique with a high volume of blockade, the phrenic usually gets blocked if you give a higher volume and if you give more anterior deposition of the drug. See here you can see the facial plane covering the muscle and the nerves. So when you deposit the drug within the facial plane with a higher volume, the drug seeps anteriorly on the anteroscalene and blocks the phrenic nerve. So this is the phrenic nerve. So the advent of ultrasound has most of the time mitigated the blockade of phrenic nerve and has produced an excellent anesthesia without producing diaphragmatic block. And in this picture, you can also see multiple vessels traversing into the substance of the brachial plexus. So these vessels usually with ultrasound guided, you tend to see lots of vessels entering into the brachial plexus. So you have to know about the vessels which enters into the brachial plexus. So at the level of the interscreen groove, you can see the transverse cervical artery. Usually the transverse cervical artery passes above the surface of the brachial plexus. Whereas at the level of the subclavian perivascular area, you can see the dorsal scapular artery going into the substance of the plexus. So these two arteries are very important because inadvertent puncturing of this artery and giving the drug can lead into local systemic local anesthetic toxicity. So coming to the microanatomy of the nerves, why microanatomy is important in case of ultrasound guided brachial plexus block is, so the arrangement of the nerves is such that if you give the drug within the endoneurium or within the perineurium, the pressure inside the nerve increases and it gets compressing the vasa nervosum and can produce a ischemia of the nerve. So always the ideal part to give is the paraneurium. So this concept of paraneurium has been emerged because of the safety of the drug deposition and effective blockade of the nerve. So this paraneurium is formed by the connective tissues derived from the surrounding musculature, and this usually covers the nerve, and this is more expansive. So if you give the drug, the compartment is very loose and the pressure effect is very meager. So coming to the interscreen block. So why interscreen block? So the interscreen block is being indicated for shoulder and arm surgeries, and for post-operative analgesia for total shoulder arthroplasty, and for surgeries on the lateral clavicle and the acromioclavicular joint. And the contraindications is, as usual, patient refusion and local anesthetic toxicity. And important contraindication is patient having poor pulmonary function, having severe COPD or pneumonectomy, and most dreaded is you should not give a bilateral block. Even though unilateral phrenic nerve block can be tolerated in young, healthy adult, whereas bilateral block will produce a severe bilateral phrenic nerve blockade. So the contraindication is the bilateral block for interscreen. So interscreening, the mnemonic for interscreening approaches. Here you can see this is the anterior aspect of the interscreen groove, and this is the posterior aspect of the interscreen groove, and this is the anterior scalene muscle, and this is the middle scalene muscle. You can see an interscreen groove between the two scalene muscles. This groove lodges the root level of the brachial plexus. You can see the C5, C6, and the C7. This forms a traffic light signal appearance. So this is a characteristic appearance of the interscreen groove. So the interscreen approach of the brachial plexus block, you tend to either keep the probe at the level of the cricoid cartilage, or you can move from the clavicle, say from the subclavian perivascular area, slowly scoop it up and then keep at the 90° to the skin, or you can straight away go and keep at level of the C6. So here you can see the bunch of grapes just posterolateral to the subclavian artery, going into the interscreen area and forming a traffic-like signal appearance. So this is a video for performance of the interscreen block. So here the needle comes from the posterior aspect. Here you can see the anterior scalene muscle and the middle scalene muscle and the interscreen groove. So this is an in-plane approach of the interscreen block, where the nerve passes through the middle scalene muscle, and exactly it is being placed at the 12 o'clock position of the C5 root. Usually the drug spreads from superficial to the deeper structure because the groove is arranged in such a way, and care should be taken not to go anterior to the groove. Why it is? Because the anterior deposition of the drug will spill over the surface of the anterscalene and blocks the phrenic nerve. So this should be taken into account. So this delineates the roots. Okay, so what other things to be taken into account when you are giving a interscalene block is, once again, the phrenic nerve, which lies on the surface of the anterior scalene muscle. So you should not keep the needle anterior to the C5. So avoiding the drug spilling over the surface of the anterior scalene and blocking the phrenic nerve. So always keep at the posterior aspect of the groove, above and below the C5 root. So what other structures to be kept in mind when you are performing a in-plane approach of the interscalene block is the branches of the brachial plexus, which is nothing but the dorsal scapular nerve and the long thoracic nerve. So these two nerves might get injured if you perform a in-plane approach of the interscalene block. So coming to the subclavian perivascular block. So why subclavian perivascular block? So the subclavian perivascular block is being called as the spinal of the upper limb, because it blocks almost all the nerves of the upper limb, except the superficial nerves derived from T1, T2, and the superficial cervical plexus. So why not interscalene? Why only subclavian perivascular block blocks completely the upper limb is, usually the interscalene lodges only the C5, C6, and C7, whereas the subclavian area also lodges the C8 and T1, and it forms the lower trunk. So the C8, T1 forms the corner pocket of the subclavian perivascular area. So this can't be blocked if you perform an interscalene groove block. So you tend to miss this lower trunk. So subclavian perivascular block naturally forms the spinal of the upper limb. So here you can see the hyperechoic structure. The white structure is hyperechoic, the black structure is the hypoechoic. So here the subclavian artery appears hypoechoic, and the nerves also appears hypoechoic. Once you push the probe down and go for the divisions and the cord and the branches, the hypoechogenicity of the nerve decreases and the hyperechogenicity of the nerve increases. This is naturally because of the accumulation of more of fibrous tissue once you move distal from the proximal part of the nerve. So always imagine about the hypoechoic structure and the hyperechoic structure. So in ultrasound guided subclavian perivascular block, the important structure to be taken into account is the pleura. So usually the subclavian artery is anterior and the plexus is posterior. The rib lies below the artery and the nerve, and below the first rib is the pleura. The dome of the pleura usually comes into a picture if you don't maintain a straight line of the first rib. So coming for the subclavian perivascular block indications, again, same arm surgeries, elbow surgeries, forearm, hand surgeries, and even for anesthesia for shoulder surgeries. And again, contraindications is patient refusal, local allergy, and then still there is a chance of phrenic nerve block with subclavian, high volume subclavian perivascular block. Because of the chimney effect, what we call it as the chimney effect is nothing but if you deposit higher volume, the spread of the drug is more of longitudinal rather than a transverse or circumferential spread. So it tends to seep both proximal and distal, and chance of phrenic nerve block is high if you give a higher volume subclavian perivascular block. So in our institution, we practice this subclavian perivascular block as modified parasagittal approach. Here you can see the probe is placed parasagittal at a 30-degree angulation to the neck. So this position makes sure that the first rib, this hyperechoic structure, has a single straight line. So this avoids the below structures, which is nothing but the pleura and the lungs, to inadvertently get punctured if you cross this white line. So this is a no-fly zone. No, you should never ever cross this hyperechoic structure. Here you can see the subclavian vein and the subclavian artery and the brachial plexus. This bunch of grapes is the brachial plexus, which is the division trunk and the divisional part of the brachial plexus, which forms the posterolateral aspect of the subclavian artery. So coming to the position, patient neck turned 45 degree to the opposite side and the pillow placed below the shoulders so that the supraclavicular area gets opened up. So here you can see the parasagittal oblique view. So here you can see the first rib as a single straight line, and you can see the bunch of grapes posterolateral to the artery. So in this video, we'll be seeing about a in-plane approach of the brachial plexus. So this is the anterior aspect and this is the posterior aspect of the plexus. Sorry. Sure. Yeah. Here you can see the first rib as a straight line. This is the artery and this is the plexus, and you can see the needle coming from the posterior. So here is the corner pocket. So initially you have to give the drug at the corner pocket so that you elevate the artery and the nerve from the first rib. Once you get a good plane, tend to negotiate the needle underneath the artery and elevate the artery from the first rib.
2 cc. 1 cc.
So this makes sure that the corner pocket is well soaked. So once the corner pocket is soaked, go for the upper and the middle trunk areas.
5 cc. Aspirate flame.
And again, The drug is being deposited at the upper trunk level now.
Aspirate. 2 cc. 1 cc. Aspirate.
This is for the divisions of the upper trunk.
Half cc. Wait. Aspirate.
Yeah. One more important point at the subclavian perivascular area is the branch of the upper trunk. See, you could have heard about the suprascapular nerve blockade, the anterior aspect. So why this block is, if you want to perform Phrenic nerve free blockade of the shoulder joint, say for shoulder joint reduction, you can perform this suprascapular nerve and the axial nerve separately, so that you completely avoid complete blockade of the upper limb and the phrenic nerve also. So here you can see the nerve arising out of the subclavian perivascular area of the brachial plexus and get lodged underneath the belly of the omohyoid. So if you give a block at this level, you sometimes tend to miss this nerve, and shoulder might get spared in case of subclavian perivascular area. So this is a short video about the demonstration of the blocks.
Approach. The patient positioning is in supine position and the head turned 45 degrees to the opposite side, and slightly lift the head, and you can visualize the muscular structures. This is the sternal head of the sternocleidomastoid, and this is the clavicular head of the sternocleidomastoid, and you can see a groove just posterior to that, which is nothing but the interscreen groove. For that, you have to mark the C4, which corresponds to the thyroid notch, C6, which corresponds to the cricket cartilage. So just elevate the neck to make the muscles taut, and slowly slide your finger from C6, that is the cricoid notch, laterally. So the first groove which you fall into is nothing but the groove between the sternal head and the clavicular head of the sternocleidomastoid, and the next groove is between the clavicular head of the sternocleidomastoid and the anterscalene, and the third groove is the interscalene groove. Okay. So this is the point of entry for the needle. So for this approach, the arm is adducted and the forearm is kept on the patient's torso to visualize the motor response. So I am using a 50 millimeter Stimuplex needle. The needle at entry point, you have to place it, orient the needle bit caudal and medial and a bit of posterior approach. So in this approach, you will be getting the response of C5, C6 and C7. Since C8 and T1 doesn't enter into the groove, you will not be getting the ulnar nerve response. So the response which you look for is the shoulder movement, which is mostly because of deltoid or the pectoralis major, or else you can get the response of the biceps or the triceps. If you get a response of the phrenic nerve, the needle would have gone more anterior, slightly go posterior. Yeah. So the next penis guided supraclavicular approach is for the subclavian perivascular plexus, which stimulates the truncal or the divisions of the brachial plexus. So for that, you have to mark the clavicle and the clavicular head of the sternocleidomastoid, and 1 inch lateral to the lateral border of the clavicular head of the sternocleidomastoid. This is the point of entry. So put your finger on the point and look for any pulsation. Okay, so you will be able to get the subclavian artery pulsation, and the needle entry is perpendicular to the skin and slightly posterior, and try to contact the first rib and walk over the first rib and look for any response in the arm, forearm or the fingers. So usually you have to go a bit more deeper and walk over the rib to look for the ulnar nerve response, because the ulnar nerve forms the corner pocket of the subclavian perivascular area. Usually a single point injection might not be adequate. So moving to the ultrasound guided blocks. So in this ultrasound guided block, I will be using a high frequency probe, linear probe. So first we'll go for the interscreen approach. Again the same landmark. So keep the probe perpendicular to the skin with the marker pointed anterior. Yeah. First is to look for the muscular structures. Can you see some hypoechoic structures? Yeah, these are the nerves which lodges in the interscreen groove. So at the level of the C6 or the cricket cartilage, you will be able to see the interscreen groove, and these are the interscreen C5, C6 and C7, and the muscle which is anterior is the anterior scalene and posterior will be the middle scalene. Okay. So usually this you will be able to see a traffic like signal appearance. Yeah. So in this approach you will be able to see the so this is C5, this is C6 and this is the C7 roots. Okay. On the surface of the anterior scalene, you will be able to see a hypoechoic structure which is nothing but the phrenic nerve. So if you go a bit more distal, the phrenic nerve moves away from the groove and the chance of phrenic nerve block is meager. If you go a bit more cephalad, the nerve moves closer to the interscalene groove and the chance of phrenic nerve block is higher, and the approach should not cross the anterior surface of the interscalene groove, because the chance of spilling over of the drug over the surface of the interscalene is very high and the phrenic nerve might get blocked. So in case of an in-plane approach, the needle is being brought from posterior to the anterior surface and it will be kept between the C5 and then the C6. So this is the target of injection. So in case of in-plane approach, the chances of injuring these two nerves, these are nothing but the branches of the C5 and C6, or long thoracic nerve bell, and this is the dorsal scapular nerve. So the chance of injury in case of an in-plane approach for interscalene groove, these two nerves has to be considered. So the next approach is the selective superior trunk block. So for that, from the interscalene groove approach, slightly slide it down. Yeah, the C5 and C6 usually coalesces to form the upper trunk. So how do you identify whether this is an upper trunk? For that you have to identify the C5 and the C6 roots. So you have to trace up to the root level by slowly moving the probe cephalad. So can you see bony landmarks there? Yeah. So this is the C7 root. How to identify whether it is C7 is by identifying the tubercles of the transverse process. C7 has only posterior tubercle and there is no any anterior tubercle, and you will be able to see the vertebral artery just anterior to the C7 root. Yeah, this is the vertebral artery which lies just anterior to the C7 root. So for identifying the C6, slide the probe a bit more cephalad and see for the tubercles. Yeah. So this is the C6 root. Here you can see the prominent anterior tubercle and a rudimentary posterior tubercle. This is called as the Chesagnac's tubercle, and this is the C6. And still slide little more careful ahead, you will be able to see the C5. So in C5, both anterior and the posterior tubercle will be same, and you can see the C5 root emerging out of it. So this is how you should be able to trace the roots. So slightly slide down and see for the C5, C6 merging together and forming the upper trunk. Yeah, the nerve which leaves the upper trunk before its division is the suprascapular nerve. So you can see the nerve emerging from the upper trunk. So just follow this branching. Yeah, you can see the suprascapular nerve coming out of the upper trunk. So this is how you identify the upper trunk, and you can give the block either before the branching or after the branching. So a minimum volume of 6 to 7 ml is sufficient to block this upper trunk. So with the same proportion, slightly slide down for the subclavian perivascular approach. So here, the parasagittal view, you tend to keep the probe in a parasagittal plane with the probe facing the patient's foot. Yeah. So slight 30-degree tilt, you will be able to see a straight hyperechoic line. Can you visualize it? This hyperechoic line is nothing but the first rib. So for subclavian perivascular approach of the brachial plexus, the rib should be kept straight so that you don't go beyond this no-fly zone. This is nothing but the lungs, and you can see the pleural sliding over here. And this bunch of grapes, the entire bunch of grapes is the subclavian perivascular part of the brachial plexus, which is formed by the trunk and the divisions. And usually, if you can see in a lot of patients, a vessel traversing into the substance of the brachial plexus, which is nothing but the dorsal scapular artery. Yeah. So this is the subclavian perivascular area, and this is nothing but the corner pocket which is being formed by the lower trunk, which is nothing but C8 and T1s. So usually this doesn't lodges into the interscreen groove, and we tend to miss it in the interscreen approach of the brachial plexus. So you can see a facial structure which separates the upper trunk from the lower trunk. So single point injection might not be adequate to block the lower trunk. So we have to give it both on the above and below the facial planes. Yeah. So next, moving on to the other nerve, which is important for us, is the suprascapular nerve, the anterior approach of the suprascapular nerve. So again, moving to the upper trunk, see for the branching of the suprascapular nerve, slightly tilt, bit more lateral. You can see the nerve moving underneath the posterior belly of the omohyoid. This is the posterior belly of the omohyoid, and you can see a hypoechoic structure, which is nothing but the suprascapular nerve, and this approach will prevent the blockade of the phrenic nerve, and it blocks only the suprascapular nerve. And this is being used for post arthroscopy or post shoulder replacement pain relief. Yeah. And the vascular structures which you have to look for is, one is the transverse cervical artery, which traverses just above the plexus. Can you see a vascular structure over there? So this is the transverse cervical artery, which usually moves just above the plexus. Whereas the other artery which moves into the plexus is the dorsal scapular artery. So this is the artery which moves into the plexus. Okay. Coming to the superficial cervical plexus, again at the level of the thyroid notch, which corresponds to the C4 level, just slide your finger at the posterior border of the sternocleidomastoid. Keep the probe perpendicularly at the C6 level. Okay. So you can see the sternocleidomastoid muscle, and this is the anterior scalene muscle, and this is the middle scalene muscle. And you can see two facial layers. The above one is the investing layer of the deep cervical fascia, and the below one is the prevertebral layer of the deep cervical fascia. And you can see some hypoechoic structures between the two facial layers, which is nothing but the superficial cervical plexus. If you pierce the prevertebral layer of the deep cervical fascia, the chance of phrenic block is 100%. Thank you. Clean approach. The patient position. Clean approach. The patient position.
Thank you. And hope this session would have thrown some light about the supraclavicular approaches of the brachial plexus. And I thank ISA Pudukkottai for giving this chance to demonstrate a few blocks. And I thank Dr. Shivashanmugam for moderating the session, sir. Thank you.
Thank you very much, Santosh. That's a quite comprehensive talk on the blocks above the clavicle. I think you've done the justice, because the video demonstration is more educative, because seeing people can understand things much better instead of mere talking on the slides. So that is very nice. So anyway, we have the discussions at the end. I think we will move to the next talk on the adjuvants for local anesthetic. Over to the next speaker. And I request the participants to post their questions on the chat box so that I can compile and then ask the speaker at the end. So it will be useful, so that unless you speak about, we don't know what is your doubts. So whatever doubt that you have, either it is a basic or advanced, don't think about it. You type your questions on the chat box so that it is easy for the speakers to answer your questions. Yes.
Yes, sir. Good morning. Good evening, everybody. First, warm greetings from Ganga Medical Center. I would like to thank the organizing team for giving me this opportunity to speak on this evening in the ISC Pudukkottai branch webinar. My topic for today is adjuvants to local anesthesia. First of all, what is an adjuvant? It's the co-administration of a pharmacological agent along with its local anesthesia in the central neuroaxial blockade or peripheral nerve blockade. Why do we ever need this adjuvant? It's because it prolongs the duration of sensory block and motor block. It fastens the onset of action, reduces the total dose required of the local anesthetic to produce a similar clinical effect. It also avoids the local anesthetic systemic toxicity as it decreases the total required dose of the local anesthetic. What is the ideal adjuvant? Ideal adjuvant should be preservative free. Proven mechanism of action should be there. It should increase in duration of analgesia, improvement in quality and duration of sensory block, and also absence of prolongation of motor blockade, and the drug should be economical and freely available. What is the rationale for use of adjuvant in our peripheral nerve blockade or central neuraxial blockade is that the pain transmission from the peripheral nervous system or in the central nervous system involves a complex array of neurotransmitters and pathways. The adjuvants can act either as agonist at the inhibitory receptors or as antagonist at the excitatory receptors. The net result is going to be it has to block the nociceptive transmission. So in this slide, it's a nutshell of your pain transmission, that is your pain pathway. I would like to highlight a few points. That is, first, the primary afferent neurons will carry the nociceptive impulses towards the central axis. That is, they travel towards the dorsal root ganglion and the dorsal horn. The dorsal horn, which is usually called as the melting pot, that is because this is the place where the synaptic transmission from the primary to secondary afferent neurons occur. And this is the place where the interneurons play their role, which are controlled by the descending pain pathways. And this is a place where extensive modulation of the pain occurs, so that it's of great importance when we talk about adjuvants. Then the secondary afferent neurons ascend up. They are of variable division. They are fast and slow. The fast is the discrimination component and slow is the affective component. The fast component travels straight to the thalamus and then release in the ventral posterior nucleus. From there, the tertiary neurons take over and then they end in the frontal or parietal lobes. And whereas the affective component gets relayed in the reticular formation, hypothalamus, limbic system, etc. This is the gate control theory of pain. In this, it's just basically opening and closing of gate through the nociceptive transmission. We'll first see how the gate opens or closes to let this transmission occur. The nociceptive transmitter afferent fibers are basically C and A delta fibers. The C causes the presynaptic gate opening by the release of substance P. This is counteracted by A beta fibers, which causes presynaptic inhibition of this C fiber input via GABA. A delta fibers, they actually inhibit the interneurons, enkephalin interneurons. These enkephalin interneurons, they act by inhibiting the postsynaptic transmission. By inhibiting the interneurons, A delta fibers are actually going to open the postsynaptic channels for your pain transmission. And these A delta fibers, as they ascend up, they also send a wing to the descending pathways. By sending a wing to the descending pathways, they actually open the enkephalin interneurons and causing the gate closure. This is a slide where I want to highlight the different drugs we use day in and day out and by various mode of administration. This forms the basis of a multimodal analgesia, right from the centrally acting drugs to the peripheral nerve, where you can see paracetamol, NSAIDs, anticonvulsants, local anesthetics, opioids. They act at different parts of these of the pain pathway. I would like to broadly classify the adjuvants into opioids and non-opioids. The most commonly used opioids are morphine, fentanyl, buprenorphine, and tramadol. As you know, the opioid receptors are found in the CNS and they are found in the peripheral nervous system only 96 hours after an inflammation. Once the inflammation occurs, the receptors are produced as shown in the figure. The receptors are produced in the dorsal root ganglia and they are transported intra-axonally via the microtubules as shown in the figure, and then they get deposited at the free nerve endings. This entire process takes a time of 96 hours. Intrathecal opioids act at different areas. That is, the dorsal horn of the spinal cord. They are transported supraspinally by the bulk of CSF flow, where they modulate the descending inhibitory pain pathways. And a small amount also diffuses into the epidural space. With subsequent systemic absorption, it results in centrally mediated analgesia, which is of minor importance. Peripherally administered opioids, they act by binding to the opioid receptors, which are deposited by axonal flow. And they also diffuse to the nerve plexus sheath to the extradural or subarachnoid space to the dorsal horn. There is also central action post-systemic intake. Coming to the mechanism of action, they couple to inhibitory G-protein receptors. This will cause the inhibition of adenyl cyclase enzyme, which causes the inhibition of cyclic AMP. They cause inhibition of the presynaptic voltage-gated calcium channels so that the neurotransmitter is not released, and they also cause the inhibition. They also activate the postsynaptic potassium channels, as a result of which there is postsynaptic hyperpolarization and depolarization is avoided. The end result of all this is hyperpolarization, decreased release of neurotransmitters, and decreased nociceptor excitability. Morphine is the first opioid drug ever used intrathecally as an adjuvant. The recommended dosage of intrathecal and epidural administration are 50 to 200 mics and 1 to 3 milligram respectively. When morphine is added to intrathecal bupivacaine, it will prolong the duration of your postoperative analgesia. It will reduce your 24-hour opioid consumption, and also it will decrease the pain intensity up to 12 hours postoperatively. Morphine is not routinely used in peripheral nerve blocks. That was because of negative results which were published earlier in a few studies. But of late, recent studies show morphine in a dose of 5 milligram as adjuvant to local anesthetic in brachial plexus block has found to prolong your analgesia in a moderate amount. Though prolonged effective analgesia is provided by morphine as adjuvant to local anesthesia, it will also produce adverse effects which are well known as respiratory depression, pruritus, nausea, and vomiting. The next opioid is fentanyl. The intrathecal dose is 10 to 15 mics. Epidural dose is a loading dose of 50 to 100 mics, followed by infusion. In epidural infusion, we use a dose of 1 to 2 mics per ml of local anesthetic. The fentanyl is also tried in peripheral nerve block as adjuvant, where prolongation of duration of analgesia is noted. In comparison to morphine, the incidence of respiratory depression is very minimal, but the major adverse effect by using fentanyl is pruritus. It is of it's a more frequent adverse effect with intrathecal fentanyl with a risk percentage of 27%. The next opioid is buprenorphine. It's a centrally acting, highly lipid-soluble partial opioid agonist. It's a more lipid-soluble than morphine and fentanyl. It has a local anesthetic-like property and inhibits the voltage-gated sodium channels, thereby prolonging the anesthesia. Its metabolites act on kappa and deltoid receptors, thereby it will produce an anti-hyperalgic effects. Buprenorphine is also used intrathecally with a dose of 75 to 150 mics and epidurally with a dose of 150 to 300 mics with reasonable efficacy. It has been studied as an adjuvant in peripheral nerve blockade with varying doses with a maximum dose of 300 mics, and it has been found to significantly prolong the duration of analgesia. Next opioid is a tramadol. It's a weak mu opioid receptor agonist, and it has properties of serotonin release, inhibition of noradrenaline reuptake, inhibition of sodium channels. The intrathecal dose is 10 to 50 milligram. The epidural dose is 1 to 2 milligram per kg body weight. Though the efficacy is lesser than morphine, the incidence of respiratory depression were least with tramadol. The major disadvantage of epidural tramadol is the incidence of nausea and vomiting while using doses more than 50 milligram. Tramadol has been studied in peripheral nerve blocks, but the results have been highly variable and unsatisfactory in many studies. Coming to the non-opioid group of drugs, they are alpha-2 agonists, vasoconstrictors, steroids, NMDA antagonists, NSAIDs, and other drugs. Coming to alpha-2 antagonists, they are non-selective imidazole derivatives. They are extensively used as adjuvant to local anesthetic, owing to the property of prolonging the sensory blockade in both central neuraxial block and peripheral nerve blocks. Coming to the mechanism of action of alpha-2 agonists, in peripheral nervous system, there are no alpha-2 receptors in the peripheral nerve, but they block the conduction in the A delta and C fibers by inhibiting the cyclic gated cation channels. Thus, they maintain the neurons in hyperpolarized state and prevent them from getting depolarized. The localized vasoconstriction occurs via alpha-1 receptors because they also have an alpha-1 activity, which decreases the absorption of the drug from the site. Coming to neuraxial mechanism of action, it binds to the postsynaptic alpha-2 receptors in the dorsal horn of the spinal cord, decreased nociceptive transmission. There is no effect on proprioception or motor blockade. There are two alpha-2 agonists known to us, that is the clonidine and dexmedetomidine. Clonidine has an alpha-2 specificity of 220:1, whereas dexmedetomidine is 8 to 10 times more specific for alpha-2, that is 1620:1. Clonidine has been used as adjuvant both intrathecally and epidurally. The intrathecal dose varies somewhere from 15 mics to 50 mics, but doses higher than 30 mics produces adverse effects like bradycardia, hypertension, and excessive sedation. Epidural administration usually occurs at a dose of 50 to 100 mics. The dose used in the peripheral nerve blocks in brachial plexus blocks is 1.5 to 2 mics per kg body weight. When utilized in peripheral nerve blocks, it decreases the block onset time as well as increases the duration of analgesia. Coming to dexmedetomidine, it can prolong the sensory blockade without prolonging the motor blockade. This is because of greater inhibitory effect of A delta and C nerve fibers relative to the motor response. The dosage of intrathecal dexmed is 5 mics with local anesthetic. This is what has been used in various studies available in the literature. The optimal dose of perineural dexmed with maximum duration of sensory blockade along with minimal hemodynamic adverse effects has been shown to be 50 to 60 mics. There is an animal study which has shown dexmed to be a neuroprotective, which causes less perineural inflammation. The most common side effects with dexmedetomidine are bradycardia, arterial and orthostatic hypotension, sedation and rebound hypertension, and syncope. The next group of drugs are vasoconstrictor. These are the oldest known adjuvants used along with the local anesthetic. It decreases the systemic absorption, prolongs the duration of action, reduces the incidence of LAST, and also a vascular marker to identify the intravascular drug placement. Epinephrine is also used as an adjuvant to local anesthetic in the dose of 0.2 to 0.3 milligram. Due to its severe vasoconstriction property, adrenaline is not advised intrathecally along with the local anesthetic. Epinephrine causes increased neurotoxicity, especially in diabetic neuropathy patients. This is because it compromises the blood supply and thus resulting in neural damage. The next group of drugs are the steroids. Dexamethasone is the corticosteroid drug being most commonly used and widely used as an adjuvant to local anesthetic in regional anesthesia. It has varied mechanism of actions. It decreases the excitability and neuronal transmission in the C fibers, inhibition of your potassium channels, local vasoconstrictive effect, systemic anti-inflammatory effect, and agonistic effect on alpha-2 adrenergic receptors. Dexamethasone is a preservative-free dexamethasone is used in uraxial block at a dose of 8 milligram has shown to prolong the duration of analgesia. The perineural dexamethasone prolongs both the sensory and motor blockade. It has shown to reduce the shivering and PONV postoperatively by virtue of its anti-inflammatory effects. Intravenously administered drug has also shown to prolong the duration of sensory and motor blockade. Side effect of this drug is transient hyperglycemia. Next group of drugs are the NMDA antagonists. NMDA receptor plays significant role in modulation and contributes to the development of the wind-up phenomena, central sensitization, and peripheral sensitization. All these occurs in your pain pathway. As your wind-up phenomena is something, there is a temporal summation of all the action potential as a synapse. Central sensitization is your when your NMDA receptors get sensitized, your threshold for the pain perception comes down. Ketamine and magnesium are the NMDA antagonists used as an adjuvant. Ketamine is a non-competitive NMDA antagonist which also possesses local anesthetic-like properties. The mechanism of action is it reduces the transmission of nociceptive information in the spinal cord. At high doses, it produces an analgesic effect by virtue of binding to the mu receptors and inhibiting the reuptake of neurotransmitters. It potentiates the effect of local anesthetic. The intrathecal dose of 25 milligram and epidural dose of 0.5 to 1 milligram per kg body weight have shown to reduce the intraoperative and postoperative analgesic requirements. Adverse effects are hallucinations and salivation. Magnesium is a non-competitive NMDA receptor and a calcium receptor antagonist. Decreases the peripheral nerve excitability with the intrathecal dose. It has an intrathecal dose of 50 to 100 milligram, showed little extension of postoperative analgesia. The epidural magnesium has been tried in labor analgesia at doses of 50 to 100 milligram. And postoperative analgesia, it has been tried at doses up to 500 milligram. In a peripheral nerve blockade, a dose of 50 to 200 milligrams prolongs the analgesic duration. The next group of drugs are NSAIDs. They block the cyclooxygenase 1 and 2, leading to prostaglandin synthesis inhibition. They are used as adjuvants to local anesthesia in intravenous regional anesthesia, intraocular and intra-articular and skin infiltration. These routes of administration also does not offer any added benefits when compared to the intravenous route. Hence, the intravenous route is alone preferred for NSAIDs as adjuvant to local anesthesia rather than the perineural route. The other drugs commonly used are sodium bicarbonate and midazolam. Sodium bicarbonate shortens the onset of blockade of the peripheral nerve blocks. It reduces the PK of the local anesthetic and brings it closer to the tissue pH so that it alters the fraction of ionized and non-ionized parts of the drug. Apart from reducing the onset of local anesthetic action, it doesn't improve the quality of blockade or its duration. The next drug is midazolam. It's a short-acting benzodiazepine acting on GABA A receptors. 2 mg preservative-free midazolam given intrathecally increases the duration of analgesia without much hemodynamic variations and adverse effects. Midazolam is used as adjuvant to local anesthetic in peripheral nerve blocking in a dose of 50 mics per kg and found out it shortens the block onset and also improves the postoperative analgesia. There has been a fear of neurotoxicity which is prevails while using midazolam perineurally, but so far there hasn't been any proper human study to substantiate this adverse effect. Multimodal perineural adjuvant. It is a technique where more than one adjuvant drug from different classes of adjuvants has been added together to the local anesthetic in the regional blocks. The drugs that are used in this technique are most commonly clonidine, buprenorphine, and dexamethasone. The so far published data is in a recent observational analysis study in a pediatric nerve block done by Tofaya et al. They used dexmedetomidine, dexamethasone, and buprenorphine all together as adjuvant. The sample size was very low and it warrants further studies. So this slide shows all in a nutshell of the most commonly used drugs in your adjuvants in your central neural blockade. Morphine is used at intrathecal dose of 50 to 200 mics and epidural dose of 1 to 3 milligram. Fentanyl with the intrathecal dose of 10 to 25 mics and epidural dose of loading dose of 50 to 100 mics, followed by an infusion dose of 1 to 2 mics per ml of the local anesthetic. Buprenorphine with the intrathecal dose of 75 to 150 mics and epidural dose of 150 to 300 mics. Clonidine with the intrathecal dose of 15 to 30 mics and epidural dose of 50 to 100 mics. Ketamine with the intrathecal dose of 25 milligram and epidural dose of 0.5 to 1 milligram per kg. Adjuvants in peripheral nerve blockade, dexamethasone with a dose of 4 to 8 milligram, buprenorphine with a dose of 2 to 4 mics per kg, dexmedetomidine of a dose of 0.5 to 1 mics per kg, clonidine of a dose of 1.5 to 2 mics per kg, and magnesium with a dose of 150 to 200 milligram. So the take-home message from my presentation would be adjuvants are safe. They prolong the duration of your surgical analgesia. They decreases the requirement of opioids in your post-op period. And they also decrease the dose of local anesthetic required to produce similar clinical effects, thereby reducing the chances of your local anesthetic systemic toxicity. And they also prolong the duration of post-op analgesia. Thank you.
Yes, thank you very much, Pavitra. That's again a comprehensive audit of all the adjuvants that are commonly being used and its dynamics. So let us move on to the third talk. I invite Dr. Mangeer Karasi to talk about the systemic local anesthetic toxicity. Even though it's quite rare, but that is one of the most feared or dreaded complications of using a local anesthetics. So let us listen from Dr. Mangeer Karasi. Over to Dr. So in the meanwhile, I'll request the participants to put their doubts into the chat box so that I can compile at the end.
Good evening all. My topic for today is local anesthetic systemic toxicity. First of all, we'll start with a case scenario. We had a case of 54 years male with a right-sided neck of femur fracture who has been posted for bipolar hemiarthroplasty. He was given femoral nerve block. using peripheral nerve stimulator with quadriceps contraction. As only less than 5 ml of drug has been injected after negative aspiration, patient started having convulsions and he was treated with 100% oxygen and IV midazolam. Later, it was analyzed with sonoanatomy and found the presence of an apparent artery between anterior and posterior branches of femoral nerve. So coming to the definition of local anesthetic systemic toxicity, after local anesthetic administration, any abnormal cardiovascular or neurological symptoms and signs, including isolated cardiac arrest, should raise a suspicion of local anesthetic systemic toxicity. So most of the reactions of last will occur within initial 1 to 2 minutes, but it can present even up to 1 hour after an local anesthetic blockade. So earliest description of last was in 1887, which highlights many of its prominent clinical features like respiratory failure, seizures, palpitations, and arrhythmias. So when we see local anesthetic systemic toxicity, it involves mainly two systems. One is central nervous system, another is cardiovascular system. So in central nervous system toxicity, it is divided into 2 stages, early excitatory phase and a late depressive phase. So the early excitatory phase is classically presented as lightheadedness, dizziness, perioral tingling, and numbness. There will be visual and auditory disturbances, and patient will be having difficulty in focusing and tinnitus. Patient will be confused, agitated. There will be muscle twitching, especially over face and extremities. There will be tremors and shivering, and also generalized tonic-clonic seizures. Then the late depressive phase, it will be presenting as respiratory failure and coma. So as we saw, CNS toxicity has 2 phases. The initial excitatory phase is because local anesthetic will block the inhibitory pathways of central nervous system. So it will present as muscle twitching, tremors, shivering, and generalized tonic-clonic seizures. Whereas the late depressive phase is because the local anesthetic will block both the excitatory and also the inhibitory pathways, resulting in CNS depression, coma, and respiratory failure. So coming on to cardiovascular toxicity, in cardiovascular system, the local anesthetic will go and bind with cardiac sodium channels and inhibit them, so thus reducing the spontaneous activity of sinoatrial node, resulting in bradycardia and sinus arrest. It has got negative inotropic effects on the heart, so reducing the cardiac contractility, and it can also cause arrhythmias. So it reduces the conduction system in the Purkinje fibers and reduces action potential duration and refractory period. It also prolongs the conduction time, so it will be seen in ECG as prolonged PR and prolonged QRS. So cardiovascular system toxicity, the manifestations can be in 3 phases. Initially, we can see hypertension along with tachycardia, and later on, myocardial depression presenting with tachycardia, and finally, there will be extensive peripheral vasodilatation leading on to severe hypotension and arrhythmias. So why bupivacaine is considered more cardiotoxic? Because bupivacaine will bind with increased affinity to resting inactivated sodium channels, and it reduces the rapid phase of depolarization in Purkinje fibers and ventricular muscles. And it has got slower dissociation, and this leads to incomplete recovery of sodium channels at the end of each cardiac cycle. So this will lead on to local anesthetic accumulation, and it further worsens the conduction defect. This is called fast in and slow out fashion. So bupivacaine binds with the sodium channels in a faster way, but it dissociates in a slowed out fashion. So this leads this is the reason because bupivacaine is more cardiotoxic. Whereas lignocaine, if you see, it is called fast in and fast out fashion. It binds with the sodium channels more faster, and it also dissociates from the sodium channels in a more faster way. So it is called fast in and fast out fashion. It also inhibits cardiac sarcolemmal calcium currents, so leading on to reduced myocardial contractility. So coming on to the risk factors for local anesthetic systemic toxicity, this can be divided into local anesthetic related, block related, and patient related. So first, let's see local anesthetic related factors. First is the type of anesthetic which we choose. Different agents have different intrinsic vasoactive effects. As we see, levobupivacaine and ropivacaine has got intrinsic vasoconstrictor property. So this vasoconstriction helps with prolonged duration of action, and it also slows the systemic absorption of the drug. Whereas if we see bupivacaine, which we commonly use, it has got intrinsic vasodilator property. So this itself can lead to toxicity. Coming on to the dose which we use should be lowest effective and weight-based doses. So based on the surgical site and duration planned, the site of injection, weight of the patient, comorbidities of the patient, Smith and colleagues have devised doses for the commonly used local anesthetic. So it can be seen like maximum dose without epinephrine and maximum dose with epinephrine. For lidocaine, it is 3 ml per kg if we are giving without epinephrine, and with epinephrine, it is 7 ml per kg. For bupivacaine, without epinephrine is 2 ml per kg, and with epinephrine also 2 ml per kg. Whereas with ropivacaine, it is 3 ml for both with or without epinephrine. Whereas with prilocaine, it is 6 ml per kg without epinephrine. So coming on to block related risk factors, the site of the block. So high risk of intravascular injection is more when we are giving interscalene block. There will be rapid systemic absorption in highly vascularized areas like scalp, bronchial mucosa, and pleura. So the order of toxicity can be that it will be more with intercostal and topical, then caudal, then epidural, brachial plexus, and last will be subcutaneous injection. So continuous infusion has got high risk of toxicity when compared to single administration. Coming on to the conduct of block, while giving block, frequent aspiration, giving a test dose, and giving an incremental injection and USG guided needle placement, all these can prevent local anesthetic systemic toxicity. So coming on to patient related factors. So increased perfusion at the site of injection can lead to increased systemic absorption. If the patient is already having a severe renal impairment, they'll be having a hyperdynamic circulation, reduced clearance. This can lead to systemic toxicity. And patient is having liver disease, severe cardiac failure, and metabolic and respiratory acidosis also worsens CNS toxicity, because in acidosis, free fraction of the drug will be more. And hypercapnia, it will increase the cerebral blood flow, and thus the amount of local anesthetic delivered to the brain will also be more, and it will further worsen the central nervous system toxicity. So if a patient is experiencing local anesthetic toxicity and patient is having seizures, our main motive is to avoid hypoventilation, because hypoventilation will lead on to hypercapnia, will lead on to acidosis, and this will further worsen toxicity. So we should avoid hypoventilation while managing a patient. So considering special populations, when we see elderly, they have reduced blood flow and organ function, and also they have reduced clearance and altered pharmacokinetics because they have associated comorbidities, and their nerves are more sensitive because reduced axonal function. When we see pediatric age group, because their liver is not that much matured, they have reduced alpha-1 acid glycoprotein levels, and they have increased elimination half-life of local anesthetic. They have reduced epidural fat, which leads to increased systemic absorption of the drug. They have increased cardiac output and local blood flow, which also enhances the toxicity. So when we see pregnant individuals, they have lower levels of alpha-1 acid glycoprotein level, and they have increased vascularity everywhere with high systemic absorption, and they have high plasma-free drug concentration. So how are we going to prevent it? So pre-procedure, intra and post-op, we should be vigilant at all these steps. So pre-procedure, before giving block, we should connect minimum AA-GBI monitors. Resuscitation equipment should be nearby, and we should choose the correct dose and correct drug for the patient, and vitals should be continually monitored while giving blocks. So intra procedure, during giving block, we should go slow. We should frequently aspirate for any blood coming out, and continual communication with the patient if at all possible, and giving ultrasound guided blocks reduces the incidence of local anesthetic systemic toxicity. So post-procedure, any peripheral nerve block catheter or spinal or epidural catheter should be labeled, and ongoing monitor is needed, as delayed last to even up to 1 hour also it can present. So we should be monitoring them. So the mainstay of treatment for local anesthetic systemic toxicity is lipid emulsion. So a lipid emulsion is an intralipid. This contains an emulsion of soya oil, glycerol, and egg phospholipids. In 1998, Weinberg and colleagues discovered that intralipid could resuscitate a rat from local anesthetic overdose. So the first 2 human cases reported were reports of ILE to reverse local anesthetic induced cardiac arrest was published in July and August 2006, and they showed full recovery without any neurological deficit. So in August 2007, AIGBI published a guideline stating that all anesthetic departments should have intralipid emulsion at immediate access, and it was again updated in 2010. So how does this intralipid act? It has 2 hypotheses. One is lipid sink hypothesis. This intralipid emulsion which we give will form an expanded lipid compartment within the intravascular space, and this will draw all the local anesthetic off its receptor site and clears it off from our body. Then is lipid shuttle or subway. This causes enhanced redistribution of local anesthetic to the liver so that it gets easily eliminated from the body. Enhance fatty acid metabolism, and it also directly inhibits local anesthetic binding to cardiac sodium channels. It also increases the intracellular calcium, so it restores the cardiomyocyte function and contractility. This has got positive inotropic effects. So this is a picture showing 20% intralipid, which we use commonly. So coming on to AIGBI guidelines. So managing a patient with local anesthetic systemic toxicity has 4 steps. First is recognition, then immediate management, then treatment, then 4th is follow-up. So first we should recognize a severe toxicity. So what are the signs of toxicity? So any sudden alteration in the mental status of the patient is getting agitated, loss of consciousness, seizures can be there or not. Cardiovascular collapse in the form of bradycardia, conduction block, asystole, or any ventricular tachyarrhythmias. So local anesthetic toxicity can occur immediately after giving a block or even up to 1 hour after block. So first we should recognize it. Then immediately we should stop. First thing, we should stop injecting the local anesthetic, call for help, and we should maintain the airway. If not able to maintain the airway, secure it with a tracheal tube. We should give 100% oxygen and ensure adequate lung ventilation. Hyperventilation is better as this will improve the pH, prevent acidosis, and this will not push the patient into further toxicity. So confirm or establish an clear IV access. If at all patient is convulsing, try to stop the seizures. We can use a benzodiazepine, thiopental, or propofol in small incremental doses. Throughout the resuscitation, we should be assessing the cardiovascular status of the patient, and we should immediately send in an arterial blood gas for analysis. So treatment mainstay is if the patient is in circulatory arrest or without circulatory arrest. If the patient is in circulatory arrest, immediately we should start CPR according to ACLS guidelines, and management of arrhythmias according to the standard guidelines. And if cardiopulmonary bypass is available at your center, we can immediately do that. If the patient is without circulatory arrest, use conventional therapies to treat hypotension, bradycardia, and arrhythmias. So then comes, if the patient is in arrest, after starting CPR, we should simultaneously start on IV intralipid emulsion. So, and one more thing is, when the patient is seizing, we should not use lidocaine as an anti-arrhythmic drug if the patient is having arrhythmias. Then is follow-up. After giving emulsion, resuscitate the patient, we should arrange safe transfer to a clinical area with appropriate equipment and suitable staff until sustained recovery is achieved. And when the patient is on continuous lipid infusion, we should regularly check for daily amylase and lipase levels, and we should exclude pancreatitis. And after treating a case, we should report the case to lipidrescue.org. And the use of if you use intralipid for a patient, it should be reported at www.lipidregistry.org. So intralipid will be for initial emulsion, initial bolus, will be giving 20% lipid emulsion at the rate of 1.5 ml per kg. It will be given over a period of 1 minute. And after giving a bolus, we'll simultaneously start an IV infusion of lipid emulsion at 0.25 ml per kg per minute. So after 5 minutes, we'll reassess the patient. If the patient's cardiovascular stability is not being achieved and adequate circulation is not yet reached, we can again give boluses 1.5 ml per kg at 5 minutes interval, and maximum of 3 doses can be given. And infusion can be doubled. If it was given at 0.25 ml per kg per minute, we can double it to 0.5 ml per kg per minute. So this is American Society of Regional Anesthesia and Pain Medicine checklist. So it also says the same thing: get help. Initial focus should be on airway management, seizures suppression, and alert the nearest facility having cardiopulmonary bypass. Then management of cardiac arrhythmias, we can follow basic ACLS protocol. Main thing is we have to avoid vasopressin, calcium channel blockers, beta blockers, or any local anesthetic to stop the reduce the arrhythmias. Then lipid emulsion 20% as we saw already, and post last events should be reported to lipidrescue.org and also lipidregistry.org. Thank you.
Yeah, thank you very much. Thank you very much, Mangerkarasi, for that lucid presentation on the systemic local anesthetic toxicity. Now I will let the floor open for the discussion. So to begin the discussion, I will just first look at the questions in the chat box so that we can answer them first, and then we will move on. So the first question is, how about 50 to 200 microgram of morphine added in the subarachnoid block to Pavitra? So intrathecal morphine.
Yes, intrathecal morphine we can take using 1 ml syringe, sir. There will be sorry.
Yeah, yes. So,
yes.
So the question is, how about the intrathecal as an adjuvant? Do you have any experience? We know the dosage is 50 to 200 micrograms. So, okay. See, among the adjuvants, so in my personal experience, as well as it is well established in literature, the intrathecal opioids are the best adjuvant in terms of analgesia. There is nothing can go supplement as like morphine, especially 50 to 200 microgram of intrathecal morphine can provide analgesia for a duration up to 18 to 24 hours. The incidence of respiratory depression is not as we think. It is not very high if you use in a deserving case. For example, a major laparotomies or thoracotomies or major Whipple's procedure where the nociceptive the load is wide range, which cannot be effectively attenuated with the conduction blockade from the epidural. These intrathecal narcotics make a big change in the outcome. So as far as my experience goes, or what I have seen in JIPMER or as of now here also, I would rate the intrathecal morphine as the best adjuvant in terms of prolonging the analgesia from the local anesthetics. So we use fentanyl as a measure to reduce the dose of local anesthetics. That is how we use. In case of the most sickest patients where you wanted to get the same effect, at the same time the hemodynamically patients has to be stable. So we will reduce the local anesthetic dose to less than 2 ml and add 25 mics fentanyl. So we use fentanyl as a measure of reducing an intrathecal dose. We use a morphine to prolong analgesia. This is how we will use the intrathecal opioids. We use morphine and buprenorphine is the most commonly used. Fentanyl we primarily use to reduce the dose of local anesthetic. So this is what is in our practice in terms of intrathecal opioids as an adjuvants. We hardly use opioids for peripheral nerve blocks because there are a lot of bias factors are there when we come to assess the peripheral nerve blockade, because what local anesthetic that you use, how much volume you use, where you inject, depends on this, the inter-individual variation is very high. So that is why even now it is not very clear that should we add an opioid to a peripheral nerve block. Whereas the alpha-2 agonist, the clonidine and dexmet, has proven well that their effect on the peripheral nerve block. So whenever we think of an adjuvants, another one is a dexamethasone. So we think of an adjuvant to peripheral nerve block, we will choose either clonidine or dexamethasone than opioids. So, and the other two proven adjuvant is, one is a soda bicarb, another one is an adrenaline. Adrenaline we use 5 microgram per ml to produce local vasoconstriction so that it prolongs the duration of action of shorter acting local anesthetic. At the same time, it reduces the incidence of systemic local anesthetic toxicity. To what ranges, if you had a 5 microgram per ml of adrenaline to a local anesthetic mixture, the systemic local anesthetic concentration will be 20 to 30% less than when you use a local anesthetic without an adrenaline. So definitely when you use a higher volume facial plane blocks or a multiple blocks or a paravertebral or intercostal nerve blocks, it is better to add an adrenaline. And adrenaline acts as a marker for intravascular absorption as well. So adrenaline is definite. Soda bicarb definitely increases the onset time, especially, I mean, many of the practicing anesthesiologists would know if you use an epidural, if you mix with the soda bicarb, you know it is more or less equivalent to a spinal. So hastening the onset of the epidural and the peripheral nerve block, soda bicarb is a definite adjuvant. Adrenaline to reduce the systemic absorption, clonidine and dexmet for prolonging the, and dexamethasone for prolonging the duration of action of peripheral nerve block. When it comes to the intrathecal, morphine and buprenorphine is a well established as far as literature, as well as the studies goes. This is regarding the adjuvants. Is there any other inputs from senior people? I would welcome.
Chairperson, sir, the question was asked by me only because I want the postgraduates to know, before they say anything, they should know how to do about it. Now, I am pretty sure Dr. Pavitra has never added morphine as an adjuvant in spinal analgesia. I'm definite. I need not ask anything about it. She has never added. See, my question is, when 1 ml of morphine contains 10 milligram of morphine, how she has taken 50 microgram? That's what I want to know. How she has added it to your bupivacaine or ropivacaine, whatever it is. What she has done, that's what I wanted to know. But anyway, you have given a clear, comprehensive picture of the thing. If they are not doing it, they should not tell it in the examination. That is my first point to all the postgraduates. Number two, even if they want to tell just like this, they should come prepared how to dilute it. See, suddenly she got stuck because even with the insulin syringe, how she will go about it? By 50 microgram. That is the idea, right? Anyway, I am worried about morphine as it produces, but morphine produces respiratory depression only if the dose exceeds 4 milligram. So that we will never add. But buprenorphine, even after 2 days, it can produce a rostral spread. We have to be very careful whenever we are adding. So better not to add and go for a continuous epidural if it is possible. Thanks.
Then what about adenosine and verapamil as adjuvants? So I have no idea because we have very limited scope because there are a lot of variations in the action of peripheral nerve block itself. We go little less on the adjuvants. So I have no idea about these two things because we have no clue about how these adjuvants changes the dynamics. So till we come to a very clear conclusion about how our block works. For example, if I use a 20 ml of 0.5% bupivacaine, consistently it produces this many hours of blockade. Once we come to that stand only, we can add anything else and see what it does. Since we have a lot of variations between the performance itself, so it is very difficult to come to a conclusion whether an adjuvant is making a difference or your injection itself is making a difference. So till that point of time, it is better to not to include any more adjuvants. Let us come to a clear-cut conclusion of how our peripheral nerve blocks works consistently. Then we can add up all those things. That's what my answer to it. And the third question is femoral nerve block. Which local anesthetic, Pavitra Mangir Karasi, that was? You said one case presentation. What was the local anesthetic was used in that case?
It was Buprenorphine, 0.5%.
Then how it had produced convulsions? Because your slide has not mentioned that. You have simply mentioned 5 ml of local anesthetic. And you have mentioned in your presentation that buprenorphine produces more cardiotoxic effect. Then how come in your case it has produced convulsions?
So that
it can produce, right?
Because it is not a hard and fast rule. Lower level, it tend to stimulate more the CNS than the cardiovascular system, because the receptors in the Purkinje fibers are more resistant. The threshold is very high for them naturally. So we are usually we have a CNS symptoms most commonly more than 80%. Only 1/5 of the cases presented to begin with the cardiovascular, not with the CNS. So CNS is the 75 to 80%. Patients exhibit CNS symptom first. 1 in 4 only we have a cardiovascular symptom. But whenever this sort of a picture, when we are doing the block, if you have a convulsion, it is a direct intravascular injection. Sometimes we may not see because when you apply a pressure, it may get compressed. When you aspirate, blood will not come, but you will easily inject into the venous system. So what is the common logic is, whenever we are seeing a local anesthetic complications while we are doing a block, it is most commonly a direct vascular injections. But when it happens after 15, 20 minutes, 30 minutes, 1 hour, it is a systemic absorption, which happens over a period of time. It not necessarily 20 minutes. Even recently, we done a study in a brachial plexus block. The Cmax, the Tmax, the time to maximum concentration is about 25 to 30 minutes. Sometimes it goes up to 90 minutes. So you should not think the systemic local anesthetic toxicity will happen within 10-15 minutes. It may happen 30 minutes or 1 hour also. So we need to pay close attention to these patients. So that is regarding that. Why cardiotoxicity is less in buprenorphine?
Yes, sir.
Because now marketing is over the period of time, people may not manufacture buprenorphine at all. It is very, very disheartening for me now. Everybody is promoting levobuprenorphine and buprenorphine. So, any idea, Pavitra or Mangir Karasi? So, is there any? What is the mechanism that these two S enantiomers are less cardiotoxic? Because the S enantiomer, the architecture, changing the architecture itself is reduce its affinity to these the conduction system. So there is a change in their affinity to the highly active sodium channel. So they are less propensity to produce an arrhythmogenic disturbances. So that is what it has been proposed. I am also trying to look at, or otherwise in the volunteer studies, they looked at the dose at which these toxicity symptoms are happening. So that is how they have come to a conclusion that these drugs has got a more threshold for cardiotoxic profile. So that is how, when we use a buprenorphine, suppose if it is happening in about 5 milligram, when you use a ropivacaine, the similar toxicity symptoms arises only we have 10 milligram of infusion. So that is how the studies have been come up to look at what threshold these drugs produces. So that is about the toxicity of ropivacaine. Buprenorphine 2 ml per kg. Sir, what is it, sir?
She has mentioned the dose of buprenorphine is 2 ml per kg. That is maximum permitted dose, 2 ml per kg. I could not understand. What is
milligram per kg become 2 ml per kg?
She has even mentioned in her talk. It is not only written like that. Okay. She repeatedly mentioned it is 2 ml. That is the reason I got confused. 2 ml per kg means for me what they will do 100 ml.
What are all the FDA approved adjuvants? Sir, I think only buprenorphine and Yes, Pavitra, do you have any?
Yes, so only buprenorphine is the only opioid is FDA approved. Others off-label we have been using in our city, sir.
Yes.
Intrathecal Dexmed is not FDA approved.
Not approved. Even clonidine, I don't think so. It is approved. Only buprenorphine, as of I am aware, it is approved from the FDA. But the literature evidence is there for everything. Anybody has got an experience of last one? She said. Anybody else? Even in the participants, anybody has systemic local anesthetic toxicity experiences?
My specific question was the experience of them intralipid emulsion in managing last. That is the point, because every time we say about dose of intralipid everything, but I have not seen that. That is the reason why, whether in their institution, whether they have seen, or anybody have used intralipid, then every theater should have intralipid emulsion handy. But we are not having it in most of the cities. It is not available. So I want it to be an eye opener. That is the reason I asked the question, whether anyone has seen.
So I have not seen, but we kept as a policy in the department. So every expiry date goes, we will make sure that it has been replaced. So we are keeping it. Theoretically speaking, when to give this intralipid, since we are not routinely using it and this complication is very rare. So only we need to exercise this phenomenon only in a simulation, so that we have to theoretically at least strong at what moment of time we should start using this intralipid. So the CNS toxicity, we all of us very well know that, because we have the potent drug at our hand, immediately you can give Midazolam, because we are very much experienced with it. Even with that, if the things are not under control, you can use a thiopentone, and airway management is not a problem for us. So these things very easily we will do. We are doing it anyway every day in, day out. But whenever there is a subtle sign of a cardiovascular system, that means you should have an ECG monitor on board. As Pavitra said it, or Mangeer Karasi said, it is need not necessarily tachycardia and hypertension. It can be a bradycardia, it can be a mere change in ST-T wave changes or prolongation of QR, any form of sudden change in the rhythm or blood pressure or rhythm, you should suspect that could be a subtle sign of a cardiovascular toxicity. So the ideal, now the guideline or the expert opinion is, whenever you see a sign of any ECG changes, that is the time itself you administer lipid emulsion, so that we can avert the progression. So in our institute, what we made a protocol is, whenever you see any change in the heart rate, either more than 10 beats of tachycardia, bradycardia, which is unexplained, or any change in the rhythm disturbances, then we should be ensure that the intralipid is available by the side. If any signs of progression from that point, we will give it. So that is how we made a theoretical conclusion how we will approach intralipid. And the most definite way of managing these patients is, immediately you alert the cardiopulmonary bypass team. Suppose if you have a CTBS team in your team, when you are seeing this itself, you activate them. Let them be ready, let them mobilize, because it's always going to take time. Once the local anesthetic is well established into the conduction system, there is no other way that you can start the heart by inotropic support or anything. You definitely need a mechanical support. So whenever you are seeing that it is rapidly deteriorating, immediately you activate a mechanical circulatory support team for heart, because this is easily recoverable if you put them onto the pump. So that is what I wanted to drive to all the postgraduate. The systemic local anesthetic toxicity induced cardiac arrest should be managed effectively, because once the drug is gone, the heart will just bounce back. So we need to maintain the cerebral circulation. Mechanical support is the key. We have to activate the system much earlier. And intralipid should be administered at the subtlest sign of rhythm or pressure changes. So buprenorphine dose intrathecally, she said very well, I think 75 to 50 to 150 mics. This is the epidural, it is 300, isn't it?
Yes, sir.
Yeah. All adjuvants mentioned in the list approved for intrathecal use? No, not at all. Only most of the things are off-label use only. Morphine, I think there is a well-established literature support is there for buprenorphine and morphine, not for the other things. So I didn't find any other questions. Is there any other questions from the participants? If it is not there, then I will hand over back to A.L. Meenakshi Sundaram sir for concluding remarks and conclusion.
Sir, we are extremely happy and delighted to have this youngest team from Ganga Hospital. Now there is a question: if we go on bypass, how long it will be needed? Just we are running short of time. We will say that depends upon the CTVS team.
Yes, sir.
Till the circulatory system recovers. That is the idea of going on a bypass.
Because we are not going to arrest the heart here. We are going to circulate it and then wait for, say, about half an hour or 1 hour later. If you load the heart and see how it contracts well, depending on how much the contractility comes back, rhythm comes back, then only slowly we will load the heart. Like how we will wean off from a cardiopulmonary bypass. It is the same principle that we use. The time depends on how fast the drugs goes out. We are going to monitor it, and then as the rhythm comes back, first we will wait for the rhythm, and then we will look for the pressure, how it maintains. If the rhythm is signed as good rate, and then the pressures are maintaining, we will come off.
So actually, this time the youngest team has delivered the best possible lecture. Even these questions are just to kindle their interest only. The next time they will be careful while they are presenting, and they should know people are also watching their presentation. That is the main thing. They should not think that people will be simply sitting. They are noted, and this youngest team has done phenomenally well. And we are really happy to have Dr. Sivashanmugam, because no other person can moderate and offer the remarks like this. He is seasoned person in that regional analgesia. That is the reason why we have picked him for this chairperson. And next week it is going to be a lower limb block. So even I request the same Sivashanmugam as to do that, because next time All India Institute Rishikesh will be participating. So I am talking with them, because naturally upper limb should come before the lower limb. So it has come. I thank personally Dr. Santosh Kumar, Dr. Pavitra, and Dr. Mangeer Garsi. Dr. Santosh is not having any questions for the simple reason he has demonstrated what he is doing. Point. And another one, he has just demonstrated how to perform a block.
Yes.
And people are also performing block, and nobody can ask any questions on that, because he has just demonstrated. That is a good thing. He has performed a good video, and these two lady doctors have done phenomenally well. Now I hand over the session to our President, Dr. Suresh Kumar. Sir, you have to unmute yourself, sir.
Thank you, sir. ALM, sir. A very wonderful session full of practical tips and able guided and beautiful discussions on the part of our chairperson. Thank you, sir, Dr. Sivashanmugam, sir. Once again, and thank the speakers. I now call upon our treasurer, Dr. David, to give vote of thanks. To Dr. David.
On behalf of ISA Pudukkottai, I would like to thank our academic chairman, Dr. ALM, sir, for successfully conducting 17th webinar academic program. Thank you very much, sir. And the special thanks to our chairperson, Dr. Sivashanmugam, Professor Mahatma Gandhi Medical College, Pondicherry, for sharing his wonderful experiences. And also thank our speakers, Dr. Pavitra Palaniyappan and Dr. Santosh Kumar and Dr. Mangeer Garsi, for sharing his wonderful academic session. And also thank our faculties and postgraduate in the Acurolai Leonologic for technical support. Thank you very much. Thank you.
Thanks, sir. Thank you.
Thank you, sir. Thanks a lot, sir.
Thank you, sir.
See you, sir.
Youngsters, keep going.
Yeah, sure, sir. Thank you.
Extremely well.